cairo. Renal business before the
متقاعدة بيه مقدم مقدم طبيب
وبشكركم للسادة الحضور وأتمنى إن انتوا تركزوا معايا في المحاضرة دي. في حاجات كتير هتبقى تقريبا اتقالت في المحاضرات التانية مش شرح يعني، فكويس إن احنا نسمع حاجات كتير مختلفة عشان الموضوع ممكن يكون ملخص يعني. فالنهارده إن شاء الله هنتكلم على renal replacement therapy in NASR. It contains of my presentation will be first an introduction, incidents, definitions, classification, reviewing all classifications, etiology, indications, what the classic labs are, the modalities of renal replacement therapy, what are the principles, the access, anticoagulation, when to start, when to stop, the intensity of the dialysis, conclusions, and finally the remedy. So as an introduction, severe acute kidney injury is obviously a life-threatening condition that may require renal replacement therapy. The incidence, this severe AKI occurs in approximately 5 to 7% of hospital patients, 30% of ICU admissions, 19% of those with septic shock, and of those ICU patients, mortality is up to 60% and 5-fold greater, regardless of any associated comorbidity. Among the survivors, 5 to 6% will finally require permanent renal replacement therapy. So what is the definition of AKI? It's currently defined as an absolute increase in serum creatinine by 0.3 milligrams or more, or an increase 50% or more in serum creatinine 1.5 times or more, and this is something that has occurred within the past 7 days, or a urine volume less than 0.5 milligrams per kg an hour for over 6 hours. We have classifications. We have an old classification which was oliguric and non-oliguric, and then there's a new classification which is the radical and the actin. Actin is basically just a modification of the radical. Radical stands for risk, injury, failure, loss, and end-stage renal disease, and in both situations we describe whether it's non-oliguric or oliguric. So in risk, the patient class risk has an increased serum creatinine 1.5 times the baseline, or an increase in the GFR of 25%, or oliguria urine output less than 0.5 milliliters per kg per hour for 6 hours. Now there's an injury, creatinine has increased twice the baseline, GFR has increased half, which is 50%, urine output is less than 0.5 milligrams per kg per hour over 12 hours. Failure is an increase 3 times the baseline, or a GFR decrease by over 75%, a urine output that's less than 0.3 for over 24 hours, or anuria for over 12 hours. Finally, the patient is left and there's a complete loss of kidney function for over 4 weeks, and this is the stage of loss. And finally, it deteriorates into a permanent end-stage renal disease, which means that it necessitates renal replacement therapy for over 3 months. The actin is a modification of the renal replacement of the radical, As we all know, I won't go to depths into the etiology of AKI, but we all know that the causes are renal, pre-renal, and post-renal. And these are the percentages where the pre-renal accounts for 40 to 80% of the causes of AKI. And of course, we have the very famous diseases like diabetes, hypertension, nephrotoxins. We have the post-renal that accounts for up to 15%, and this is basically urological causes. And we have the renal, glomerular only 5%, tubular 55%, interstitial 2%, and vascular 3% of the total causes. What are the indications for renal replacement therapy? There's a very nice mnemonic which is called IOU, and this means, it's just to summarize, when you dialyze the patient. A stands for acidemia, which is metabolic acidosis that is refractory to treatment with sodium bicarb, pH less than 7.1. E is for electrolyte disturbance, which means a pH which means a potassium is more than 6.5, whether it's refractory to treatment or rapidly rising hyperkalemia. A stands for intoxication with a dialyzable substance that we can remember by slime. Slime being salicylic acid, lithium, isopropanool, and something that we commonly use in enemas like the magnesium laxatives, and ethylene glycol, which means intoxication by something that can be removed by dialysis. O stands for overload, again refractory to treatment with diuretics, and finally uremia, either a BUN 80 to 100 or uremia resulting in complications like pericarditis or encephalopathy or GIT treatment. The classic labs of AKI, again, they respect whether the cause is pre-renal, intrinsic, or post-renal. So the criteria are the first three. I don't think that most of us measure: the urinary osmolality, the urinary sodium, the fractional excretion sodium. But finally, there's the BUN to creat ratio, which is less than 20 in pre-renal, less than 15 in intrinsic, and more than 15 then in post-renal. Okay, what are the modalities of renal replacement therapy? We have intermittent hemodialysis, which is what we're all familiar with. We have continuous renal replacement therapies, and we're going to discuss the differences in the indications. We have hybrid therapies, which are a combination of therapies, for example, SLED, and finally we have the peritoneal dialysis. So, continuous renal replacement therapy was first introduced in the 1980s, and this means that you do a continuous form of hemodialysis depending on a slower rate of removal of solutes or fluids. It includes all types, which are hemofiltration, hemodialysis, hemodiafiltration, and all of them they use an AV axis or a VV axis. So, in continuous VV, for example, we use a blood pump and we use convection. In continuous VV hemodialysis, then use a pump and you have to use a dilator depending on the countercurrent blood flow. It's slower in terms of removal of fluids, but it removes solutes more. And then finally we have the hemodiafiltration, which is a combination of both. It combines diffusion for the small solutes and convection for the larger ones. And this is most commonly used in ICUs, and that's why not many people are familiar with the hemodiafiltration. What are the downsides of this continuous therapy? First of all, it requires arterial cannulation plus a venous one, and you depend on the patient's blood pressure. So there might be an unreliable flow, especially if the patient is hypertensive or if he has a peripheral vascular disease. And of course, it requires more anticoagulation being continuous than we're talking about at least 6 hours continuous with the machine, so you have to use anticoagulation. So in this case, we prefer the veno-venous than the arterial-venous because there's a lower risk, and you have only one dual lumen catheter, and the flow is more reliable. Just to go briefly over the principles of dialysis, dialysis is basically diffusion passively of solutes according to a concentration gradient, and so obviously this is much better for small molecules. Whereas ultrafiltration depends on convection for removal of both solutes and fluid across a pressure gradient, not a concentration gradient, and so this is better for medium-sized molecules. So of course you can now imagine that once you do hemodialysis and you combine that with hemofiltration and hemodialysis, you combine both, so you get hemodiafiltration, which is best, so you're removing little molecules, large molecules, and removal of fluid. So we're talking about a dialysate that flows countercurrent to the blood flow. So the blood flow passes this way. You have the dialysate passing counter-current, and you have exchange of the urea and creatinine from the blood to the dialysate, and you have the calcium and the bicarb infusing from the dialysate to the blood, and they're both passing a counter-current mechanism across a sieving filter. That's for hemodialysis. Hemofiltration, it's not a passive diffusion. You depend on hydraulic pressure to produce a gradient that then induces convection, and through that you remove water and solutes. HDF, again, is a combination of both. So we can now suspect that hemofiltration is used in ICUs basically for multiple organ dysfunction patients or septic patients. You use a semi-permeable membrane, and of course we said that you use convection mechanism. You do not use dialysate for hemofiltration, so that's why it's used for hemodynamically unstable patients, because we know that dialysate sometimes lowers the blood pressure in patients, and we depend on seeing properties of the filter. What's the rationale behind hemofiltration? Why do we use it in the first place? Because larger molecular weight molecules and solutes are not efficiently removed by other methods like hemodialysis. So the advantage is that you remove the large molecular weight solutes that are small enough to pass through the filter. You depend on pressure gradient, and the rate of removal is proportional to the applied pressure that you have. You can either do the volume substitution pre-filter, in which case it's called pre-dilution, or post-filter, in which case it's called post-dilution. Its selectivity is low. The efficiency is much better for high molecular weight solutes, and it's reduced for the smaller molecular weight. And that's why hemofiltration is much better for larger molecules like small proteins and inflammatory mediators and cytokines, and that's why we use it in ICU for septic patients. But do not expect a great reduction in the urea. Why? Because the efficacy is much reduced for small molecular weight substances such as urea and creatinine, so it's not very good in reduction of those. The mechanism and the amount that we use is according to respective water flux, and it could be unrestricted, restricted, or there's no restriction at all for the solute removal. It depends on the size of the solute, the size of the pores and distribution, the molecular mass, the shape and configuration, and finally the charges that are present on the filter and on the solutes. Okay, so what's the difference between using a high flux and hemofiltration? If we're talking about removal of middle molecules, and the main thing why we want to remove middle molecules is to prevent something called amyloidosis that patients develop after years of dialysis. Let's say about 7 to 10 years of dialysis, they develop this because nobody took care of preventing the accumulation of middle molecules. So high flux, you use, they have thousands of microfibers that have a large pore size, and this depends on diffusion. Versus hemofiltration, it depends on hydraulic pressure, but then induces convection, and you use a pressure gradient. So both of them are used for removal of middle molecules. Again, we said that hemodiafiltration is basically a combination of hemofiltration and hemodialysis. But as Dr. Hazim stressed yesterday, that using a high flux necessitates the presence of ultra-pure water, otherwise you're actually harming the patient because of the back filtration and is not benefiting from the high flux. And of course you have to do a substitution of the fluid that you remove, and you have to infuse that directly into the bloodline. So hemodiafiltration has the advantage of combining removal of both the large and small molecular weight solutes. What do we replace with? The fluid has to be, of course, isotonic, and it contains the volume and the electrolytes. It has to be of high purity because you're infusing something directly into the patient's blood. You can use lactate or acetate, which are eventually going to be converted into bicarbonate. But of course, in patients with liver disease, they can't convert the lactate to bicarbonate, so they might develop lactic acidosis. In this case, it's contraindicated to use anything other than bicarb, which is a must. Another modality is called SCUF, or slow continuous ultrafiltration, and this is basically used for overloaded congestive heart failure patients. It's basically to remove water and not solutes, and of course, if you're going to remove water, you will not replace by a fluid. Another modality is sustained low efficiency daily dialysis, also known as extended daily dialysis or slow continuous dialysis. This is a hybrid therapy that is basically the intermittent dialysis that we all perform in our center, but you don't use 4 hours. You have to use at least 5 hours, or maybe even more. And you individualize your own prescription according to your patient, your nurses, the hypercoagulability state or the disease tendency of the patient. It uses conventional dialysis machines. It's very flexible. You don't need any other special filters or special machines. So the advantages is that it's flexible, there are reduced costs, and maybe you don't need any anticoagulation at all. What's the access for all of the renal replacement therapies? You can use either arteriovenous or venovenous. Neither of them have proven more effective than the other, and of course all of them may require systemic anticoagulation. Okay, so what's the difference between the AV and the VV? AV, you can dilate the femoral artery. Sorry. And you depend on the arterial pressure of the patient from the femoral artery that's going to push the blood through the filter into the femoral vein. So the filtration rates are typically low because you're not using a blood pump, and of course they're going to be very bad if there's a hypertensive patient or a patient with peripheral vascular disease. So it's unreliable, and that's a disadvantage. But the advantage is that it's simple and you do not need a blood pump, so you don't even need a machine. Okay? Whereas the renal venous, you have to have a blood pump to push this blood. So you use a large vein, whether it's femoral or internal jugular or the carotid, and you use that for the blood. And the advantages of this is that there's better control of blood pressure, there's a safer removal of the solvents and the water, it's smoother, and you just have to cannulate one vessel. And of course, these are the nomenclatures for all of the things that we've said. So you can use hemofiltration or hemodialysis or hemodiafiltration either in the AV method or the VV method. And then finally, we have the peritoneal dialysis. So what about peritoneal dialysis in acute kidney injury? It's the least useful form of a continuous renal replacement therapy in ICU. What's the rationale behind it? It's diffusion. Blood in the capillaries of the peritoneal membrane are exposed to dialysate in the abdomen. And again, it could be either continuous like the CAPD or other forms like the journal, or it could be intermittent. But the disadvantages, of course, because you're depending on the membrane itself, there's an inefficient solute or volume clearance if there's a poor intestinal blood flow. So if you don't have blood flow, there won't be a good exchange of solutes across the membrane. Again, if you have peritonitis, then you're not allowed to use it, and it itself induces peritonitis. You can't use it if you have any intra-abdominal pathology like adhesions or cancers or any mechanical obstruction. And finally, it causes a respiratory burden. Out of the randomized controlled trials that they did, they found no difference between hemodialysis or PD, or maybe even they found that PD was inferior for AKI patients. So what do we use with PD in AKI patients? It's not frequently used, but if HEF is not available or HF is not available due to cost or lack of expertise, then PD would be safer for those hemodynamically unstable patients. What about anticoagulation? Of course, because we're talking about continuous therapy, we have to prevent clotting. This could be tricky in ICU patients because they always have the dilemma and paradoxical bleeding tendency versus hypercoagulability states. So it's a bit difficult for ICU patients. How do we do it? We have the options. We have either systemic anticoagulation with heparin or low molecular weight heparinoids or thrombin antagonists, or regional citrate, and we're going to talk about that, or other regional anticoagulation like heparin proteinine. How do you choose your anticoagulation? It depends on the potential risks of the patients and the benefits that you're going to gain from this anticoagulation. So for example, intermittent, the usual dialysis that we all perform, usually we use unfractionated heparin or low molecular weight heparin. For the continuous, it's much better to use regional citrate anticoagulation, but in some patients that don't have contraindications for citrate. If you have a contraindication for citrate, then you're going to have to use heparin. Okay, what about those who have heparin-induced thrombocytopenia or heparin hypersensitivity? Then you either use direct thrombin inhibitors like arotropin or factor Xa inhibitors, or no anticoagulation, in which case you have to do a frequent wash of the extracorporeal circuit. What about regional citrate anticoagulation? This is basically that you infuse citrate at the beginning of the circuit, and the idea is that citrate chelates the ionized calcium. So as you can imagine, the patient's serum calcium is going to be low. So this requires a systemic calcium infusion to replace the lost calcium, and you have to keep a target extracorporeal blood citrate 4 to 6 millimoles and pre-filter ionized calcium less than 0.35 millimoles. So obviously it needs calculation. It might be difficult. There might be errors in the calculation, and finally you might subject your patient to hypocalcemia. So, okay, what are the advantages of this regional citrate anticoagulation? Is that you avoid systemic anticoagulation and bleeding tendencies and heparin-induced thrombocytopenia, and it acts as a buffer. But the disadvantages is that you have potential metabolic complications, whether acidosis, alkalosis, hypocalcemia, hypernatremia, hypermagnesemia. Of course, it's a complex protocol that requires frequent monitoring every 6 hours of the ADG, the calcium level, the sodium level, the magnesium level, the anion gap, and finally it's more expensive, so as a result it's not very practical. When do we start doing renal replacement therapy? There's a great controversy, so there are no clear indications when we start doing it, and there are all non-randomized control studies that say that early initiation reduces mortality, and of course there are always theoretical benefits that it might reduce the organ injury, and it might reduce the organ injury resulting from acidemia or uremia or fluid overload. But the ATN study found that increasing the intensity did not really improve any outcome in terms of morbidity or mortality. There was one randomized control study on 106 patients that had the criteria of AKI, and it resulted in survival after 28 days and recovery of the renal function. Another study by Carvelis compared the early versus the late, and there was a meta-analysis of 15 studies that associated with low mortality because the patient started early renal replacement therapy, but then the study was criticized by being heterogeneous and biased, so it wasn't really taken into account. So there is a beneficial impact on survival and outcomes, but in only selected patients, but it's not confirmed by many studies. And what we say is that initiation prior to the development of advanced uremic symptoms, that's more likely the best description of the timing of the initiation. And so when there's a BUN that reaches 80 to 100, then you start dialysis, or of course if you have any symptoms of uremia like hemorrhage or cardiac manifestations or brain insults. As in terms of fluid, there's no indication or no threshold for fluid overload when to start. Okay, when do we stop? If we don't know when to start, we don't know when to stop. Again, there's no consensus, nothing agreed upon as to when to stop. So they just said that maybe if there's evidence of recovery in terms of better urine output, reduction of the serum creat or improvement of the creatinine clearance, then we can stop. Continuous HF and continuous HV. It means, of course, without interruption. Again, what's the advantage of something continuous is that you avoid the hypertension and you do it for hemodynamically unstable patients. You have to replace by fluids, so they have to continue receiving infusions, and you need a dialysis circuit. The treatments, okay, comparing continuous versus intermittent. So we said that the continuous has to be done in an ICU setting. There could be a little difference in the outcome between both of them. But most trials, they excluded patients with major hemodynamic issues. So the comparison was not very fair, and they couldn't really conclude which one is better. So what we know is that there's an ongoing debate whether continuous is better or intermittent is better. There are only theoretical benefits, and all the randomized control studies showed no difference in terms of improvement. At least 7 studies and 3 meta-analyses did not demonstrate any difference in the outcome. So does this mean that continuous is useless and the standard that we have to go back to intermittent? No. There are specific subpopulations that might benefit from the intermittent and other populations that benefit from continuous. So I tried to do a table just to demonstrate the differences and compare between both. So when we talk about continuous in terms of studies, it's unknown if there's better recovery of the renal function because you preserve the hemodynamic stability. It's unknown if you have an adequate removal of solutes because of the longer dialysis. We're not sure if there's improved removal of cytokines. There's no evidence on that. Whereas intermittent is practical, it's flexible, you use the same machines, you don't need expensive machines. We're talking about a cost that is half half the cost of of the continuous one. You have fewer bleeding complications, less filter clogging, and a better solute removal. So who benefits from this one and who benefits from this one? The continuous is for those with hemodynamic instability, for patients who have AKI combined with hepatic failure, and for those who have acute brain injury. You have to do continuous. Otherwise, your patient might die from the risks that he's subjected to if you do intermittent with these patients. As for intermittent, the populations that might benefit are those with a high bleeding risk, like after surgery, or acute treatment when you don't have time to rest your patient over 6 to 10 to 12 hours, as in hyperkalemia or rhabdomyolysis or poisoning or hemolysis syndrome. What did the KDIGO say about the initiation, the kidney dialysis initiative goals and outcomes? Okay, they said that renal replacement therapy, of course, is a life-threatening condition. So how do you choose when to do your renal replacement therapy? You have to depend on conditions in your patients and lab tests, and you have to consider the broader clinical context. So you're not looking just at one BUN or one serum creatinine level. You have to take the patient as a whole in terms of his personal condition and his lab. They said that you have to use a biocompatible membrane, and they said that these are, whether continuous or intermittent, they're both complementary therapies. So there's no one method that's superior over the other. You have to select your patient and accordingly select his own agenda. But they agreed that the CRRT is better for hemodynamically unstable patients and those with brain injury. It's better to use bicarb rather than lactate because your patient in ICU probably has some kind of liver insult as well, and you have to use a replacement fluid. Again, you have to prescribe the dose for your patient before he starts dialysis. So you can't leave it as a surprise. You have to determine your goal and what you're going to do for this patient, how many hours, how many days, what modality, before you start treating the patient. They recommended a KTOV of 3.9 per week if you're talking about intermittent, and equivalent volume of 25 milliliters per kg if you're talking about continuous. They said that intermittent is 3.9 kg per week and continuous 0.25. For those who are dialysis dependent, and we're talking about achieving a KT over V value of 1.2 or continuous 20 milligrams per kg an hour. And again, both methods are complementary, they're not antagonizing. When you discontinue, the KDIGO said that if you find a recovery of the condition, and they advised against the use of diuretics in AKI. So what are the conclusions? That renal replacement therapy is extremely variable in many modalities. Among all these modalities, there is little consensus on the criteria of when to start, what to use, when to stop, and the intensity. So how are we going to assess and how are we going to decide? It depends on the patient, the age, the severity, the comorbidities, the logistics. What does that mean? It means that the organization itself. Do you have the facilities? Do you have the machine? Do you have a trained people? Do you have expertise? Do you have the money? Does the patient have the money? Can the patient afford to stay in the hospital? So all these things determine your essence and how you're going to treat the patient. Of course, you must take into consideration the rifle classification or the AKI staging to determine whether your patient needs this therapy or not. You have to differentiate the etiology. Is this patient a single organ AKI or is multi-organ? If he has a liver insult as well, then there are very certain things you have to take care of. The literature in 2008 proved no difference in outcomes between intermittent and continuous. Intensive renal replacement therapy didn't improve any clinical outcomes. And finally, we know that continuous is for hemodynamic unstable patients. We know that there are very few randomized controlled studies. None of them suggested any beneficial outcomes of hemofiltration versus hemodialysis. Why am I saying all these studies? Because to show that there's no one single technique that is superior. You have to choose a technique according to the patient. And sometimes we know for sure that hemofiltration increases clearance of medium to larger molecules. But we also know that initiation in some patients, earlier treatment means better recovery. This might apply to some patients, whereas in other patients, this might subject your patient to hemodynamic hazards, and you might harm your patient rather than him benefiting. We're talking about intermittent high intensity. They prove that equally effective, and again, we have to stress that all these modalities are complementary, they're not competing, and they depend on the local expertise and availabilities. You have to individualize your agenda for the patient, and as we said, it may improve, but sometimes it worsens. So what were the recommendations that were in literature? They were all about the types of studies that we needed. That first of all, they have to include high flux dialyzers for the patient if you're comparing superiority of hemofiltration to hemodialysis. There's no sense in trying to compare which is superior, hemofiltration or hemodialysis, if you're using different filters. Obviously, a high flux will result in better outcome. So they don't have a study where they use high flux for both. So that's one drawback. The other recommendation was that they need to evaluate the impact of hemofiltration on versus hemodialysis on intermediate outcomes. And the last thing is that reduced risk of serious falls, invasive stroke in the intermittent high intensity group again should be validated.
Thank you, Dr. Noha, for this eloquent lecture. And now checks all more questions? Thank you, Dr.